This is the second part of the Chapter 4 lecture. It starts with transcultural communication, bridging the gap. Conflict can arise when the nurse comes from a cultural background that differs from that of the child and family. Such differences might influence the approach to care. Healthcare professionals need to be aware of their own values and beliefs and to recognize how these influence their actions with others. They also need to be aware and respect the child and family's values and beliefs. The initial nursing assessment should always address values, beliefs, and traditions. The nurse can then consider ways in which culture might affect communication style, methods of decision-making, cultural adaptations for nursing intervention, and other behaviors related to healthcare practices. During the initial interview, the nurse ascertains the following information related to the child's care, decision-making practices, such as are the decisions made by individuals or collectively as a group? Is it the male that's making the decisions instead of a female? Child rearing practices. Who are the primary caregivers? What are the disciplinary practices? Family support. What is the family structure? To whom do the patient and family turn for support? Communication practices. How is the information communicated to the rest of the family? Health and illness practices. Do the family members seek professional help or rely on other resources for treatment and advice? Because language barriers can greatly affect the provision of health care, effective communication with a child or family for whom English is not the native language is an important challenge. The optimal or best approach to this issue is to access a trained interpreter or a family member or friend who is proficient in English. I would say normally you're going to see, that's from your textbook, but normally a trained interpreter is who you're going to want to use. You don't want to use family members to translate. You want someone that has been trained to translate in the patient's native language. It is recommended that the child not be used to interpret. So a lot of times either there's an interpreter on staff that can come in and function as an interpreter. A lot of facilities now have a computer type system where you can have sort of Skype with an interpreter who can interpret for the patient and interpret what the nurse or the doctor is saying. So in terms of language barriers, we want to use the appropriate interpreter, whether it's a trained person or who's local or a trained person who we access through some sort of Skype type technology. We do not want to use family members or the children to serve as translators. In terms of developing and maintaining trust, trust is important in establishing and maintaining therapeutic relationships with families. Trust promotes a sense of partnership between families and nurses. Becoming overly involved with the child or family can inhibit a healthy relationship. Your textbook on boxes 4.2 and 4.3 have some warning signs of over-involvement and under-involvement that are pretty self-explanatory. The basic takeaway is that we must always maintain professional boundaries, which require that the nurse constantly be aware of the fine line between empathy and over-involvement. There is a purple nursing care box that starts on page 53 for communicating with children and families. You'll need to review that box on your own, along with the critical thinking exercise. Good little exercise. The storytelling box 4.4 ties back in with that purple nursing care box that discusses communicating with children and families. Page 58 has table 4.5, self-esteem in children, communication practices. I want to have you look over that on your own. Again, it's pretty self-explanatory, not too complicated of concepts there. Techniques to enhance self-esteem, praise efforts and accomplishments, practices that would harm self-esteem, criticizing efforts and accomplishments, right? So it's one side's the good, one side's the bad. Use active listening skills, would enhance self-esteem. Be too busy to listen, that could harm self-esteem. So those I'm going to have you look at on your own. In terms of communication, so I'm thinking back to some important things. Active listening, using I statements. So if you have to deliver bad news or something, I don't want to say bad news. If you have to deliver something that could anger the other person or offend them, The technique that you want to use is to use I statements. So let's say you're the nurse and you walk into a pediatric patient's room and they have the child in the crib with the side rails down, right? So you walk in and you're scared for the child's safety. So what you do not want to do is use you statements. You know, you're going to end up with your child being hurt because you left the side rail down. Or, you know, I'm trying to think of another way to word it. You really shouldn't leave that down like that, or else your baby's going to fall out, that type of thing. So how could we say it differently using an I statement, right? So I, as the nurse, could go in and say, oh, I'm a little concerned about the baby's safety with the side rail down. You know, it's evidence-based practice says that it's best for the rails to stay up to keep the baby safe. So again, if you're delivering messages, the patient can receive a message that might otherwise offend them better if you're using an I statement. All right, so I'm going to let you look through the rest of those on your own. If you then want to look at the other two tables at the end of the chapter, table 4.3 talks about developmental milestones and the relationship to communication. So it talks about infants, toddlers, preschool, school-age children, and adolescents, sort of where their language development's at, and sort of at the right side then, suggested communication approach. So for toddlers, let's say, language development, 2-word combinations. Participate in turn-taking in communication. No becomes a favorite word. Able to use gestures to verbalize simple wants and needs. Under suggested communication, learn the toddler's words for common items and use them in conversation. Describe activities and procedures as they're about to be done. So you don't want to tell the toddler, you know, in half an hour before you're doing an IV stick that you're going to do an IV stick. Use picture books. Use play for demonstration. Be responsive to child's receptivity towards you and approach cautiously. And preparation should occur immediately before an event. So again, you don't want to prep them a little too early. So those I want you to look over and be familiar with. And then finally, if you look at table 4.4, it talks about considerations and choosing language. And we talked about this a little bit in the chapter 2 or 3 lecture, I can't remember which one, where we talked about the pediatric patient might not know what a stool sample is. Or when you say you're going to put them to sleep, they could get scared that you're going to, you know, cause them to die. Who knows? So that table 4.4 has some examples as to how those phrases could be reworded. So I know you were given a couple to try and reword, and you can compare it using that table 4.4 to see if your answers aligned up with what the textbook gave us, some sample explanations that could be used instead of those more confusing choices of language. Communication of children with special needs won't be tested, so you can skip that part. We got an end of the chapter question here. Which approach would be best to use to ensure a positive response from a toddler? Go ahead and pause the video and read all the questions and pick out your answer. If you chose answer A, assume an eye level position and talk quietly, you picked the correct answer.